Jorge Terrazas. I'm a nurse practitioner student, and I was just wondering if it would be okay if I can assess you. Today, what we're going to be assessing, we're going to assess your chest. We're going to assess both your front and the back side of your chest. I'm going to be checking for any abnormalities. I'm also going to be listening to your lung sounds, and I'm also going to be listening to your heart sounds as well. Would it be okay to proceed with the examination?
Yes.
Perfect. So we're going to start off. At this point, I would have the patient in the gown, and I would expose the top part of their chest. I would be looking for any deformities. I would also go ahead and I would begin to palpate, making sure that there's no tenderness. Does any of that hurt you as I'm touching your chest?
No.
No? Perfect. Okay, I'm just going to move your hair right here. Okay, so no tenderness in any areas of the chest?
No.
No? Okay, perfect. At this time, I would also go ahead and take advantage while I have the patient sitting in the upright position, and I would start listening to breath sounds at this moment. Okay. So if you could, I'm just going to ask you to go ahead and take a breath in for me. Go ahead and release. Okay. So I'm getting good breath sounds at this moment while I auscultate all of the breath sounds. And I'm comparing each side to the other at the same level. Breath sounds are nice and clear, nice and even. I'm going to also go ahead and go over to the side. Go ahead and lift your arm for me. Right there, thank you. I'll be hearing some nice clear breath sounds. Okay. So I'm also going to listen to your breath sounds like I had mentioned before from the back part of your back. So if I could just kind of have you sit forward for me, turn a little to the side, and I would continue to listen to the breath sounds. I would also open the gown up at this point. I would inspect the patient's posterior side, making sure that there's no deformities, making sure that there's no unevenness while she breathes in, as she's inhaling. I've also taken into account the amount of breath she's breathing per minute. At this point, she is breathing 14 breaths a minute. Anteriorly, they are clear breath sounds. So now listen to her breath sounds posteriorly. So I'm starting at the very top lobes. I have nice clear breath sounds with a nice pitch as she breathes in, as the air is traveling through the lungs. Since the air is filling up the lungs at this point, I am hearing a nice clear whistle sound, and the air begins to move further as she exhales. I'm comparing all breath sounds from the right side to the left side, making sure that they are equal. And then I'll compare the left lower node as she breathes in to the right lower node. So at this point right now, since I do have her with her posterior side towards me, I will ask the patient to go ahead and take in a deep breath for me. While I am doing this, I'm going to place both my hands and I'm going to grab the sides. I'm going to place my thumbs in the center, and then I'm going to ask the patient to inhale for me, and I'm going to watch for evenness, separation of my hands. So right now, if you could, I'm going to ask you to, would you please take a deep breath for me? Deep breath. Go ahead. So I have equal movement on both sides. There's equal rise, and there is equal separation of both hands as well. At this time, since I do have her facing opposite of me and I'm able to see her posterior back, I'm going to also check for the sound pitches as she speaks to me while I am auscultating on the lung sounds. So I'm going to have her go ahead and say 99 for me, and I should have a nice resonant sound. Any type of dullness that she may have, or any type of hyperresonance, could be indicative of fluid in the lungs, of masses, of air in between the skin, and then at that point I will either have like I said, a hyper resonant or a dull sound. So I'm going to auscultate the different portions of the lung at this point. Go ahead and say 99.
99.
Again.
99. 99.
Again.
99. 99. 99. 99. 99.
So the patient does have resonant sounds as she's breathing. As she's stating 99, they're a little higher pitched on the upper lobes, and then it gets a little softer, but there's no really big changes. They're both equal on both sides. At this point, I will also check for fragmentus. I will do that by placing the lateral aspect of my hand on the intercostal spaces, and I will have the patient go ahead and say 99 for me again. Go ahead.
99.
While she's saying 99, I should feel a nice vibration.
99.
And I am feeling vibrations in all the intercostal spaces.
99.
Again.
99.
And I do have that little vibration that I'm feeling on the lateral part of my hand. I'm going to go ahead and check the left side now.
99. 99. 99. 99.
Perfect. So I am going to ask you to go ahead and face forward now. At this time, I will also take the time to go ahead and I will look at the patient, make sure that there's no jugular vein distension. We also want to check for jugular vein pressure. We could do that while the patient is either sitting at an incline of 40 degrees or completely laying down. When we have the patient laying down, we will actually be looking at the point of the Louis. This is the portion where we'll be measuring from. At this measurement, it's usually from 5 to 7 centimeters of water, just to make sure that this jugular vein distension is below that. So we'll go ahead and be doing at this point. I'll be asking the patient to lay down. If you can lay with your head over here onto the side of the bench for me. So while I have the patient laying down, I'm going to expose her so that I'll be able to see, excuse me, I'll be able to see her clavicles. I'll be able to see also the suprasternal notch, and I'll be able to feel for the arch of Louis right here. The arch of Louis right here will be a guide so we could see how the jugular vein pressure is at this point. So what I'm going to do, so I could actually assess the external jugular vein, I'm going to ask her to go ahead and take a deep breath for me, and then you're gonna bear down. Okay, so I'm gonna straighten your head out. Now I'm gonna have you look a little to the side, right there. So you're gonna go ahead and take a deep breath, hold the deep breath, and then kind of push down. As she pushes down, I do note that I have my jugular vein right here, the external jugular vein. I palpate that. It's a nice rubbery vein, and it goes down and kind of disappears right to the clavicle. I will also hold a little pressure so I can see the filling, and then I will release it, and I will see that it's collapsed. If the patient had jugular vein distension, the external jugular vein distension at this point, that would be indicative of a higher JVP, the jugular vein pressure, and I would know that it's higher than 6 or 7. So I see that it is below that point at this moment. So I will go ahead and ask the patient to go ahead and look. I am also examining the patient where I will be seeing her carotid pulse. I see the carotid pulse on her left side. I'm going to go ahead and palpate it. I am able to feel a nice pulse. It is a normal pulse. It's not thready. It's not bounding. I'm also going to check on the left side. On the patient's right side, and I do feel a nice pulse, regular nice pulse. It is not bounding, it is not threading. While I do have the patient laying down, I will also be palpating her chest at this moment. No tenderness. You're not having any pain right there. at this point, I am going to go ahead and I'm going to begin to percuss. I would start on the patient's lower left side. This space right here is called Trout space. I should hear, I'm going to go ahead and percuss by placing my hand in between the intercostal spaces, and I will give it a tap. And I should have a nice resonant sound. While you're percussing on Trout space, you can also hear a dullness. That dullness is going to be because of the patient's spleen. You could also move over to the right side of the patient, and we'll do the same procedure. We'll put our hands in between the intercostal spaces. You give it a nice tap. You'll hear nice resonant sound. And when you get to the part of the lower spot, you will also hear a dullness, and that's going to be because of the patient's liver. So while I'm here, I also want to see if I could see the point of maximum impulsive, the PMI. While the patient is sitting, if the patient is very thin, you can see that on the left side around the 5th intercostal space. And if you are unable to see that the patient has that PMI and you can't see the heartbeat, what you can do is with the palm of your hand, you could place it and you should be able to feel a nice heartbeat. But the best way to have this and be able to feel the PMI would be to have the patient turn over to their left side and then just kind of watch, and you'll begin to see the pulsation. So at this point, if I can have you turn a little over to your left side. Right there, that's good, that's good. You don't have to go all the way. Right, you're good. Lean back this way. So at this point, I'm going ahead and I'm looking, and I do see that there's a little pulsation on this area. And the landmarks would be the 5th intercostal space. So at this point, I'll also take the time. That way I'll be able to listen to her heart sounds. We're going to start at the PMI. So with the diaphragm, I'll apply some firm pressure, so that way I'll be able to hear the heart. So I do hear the heartbeat. It is a nice normal heartbeat. I could hear S1 and S2 sounds. I hear no S3 after the S2, or I hear no S4 right before the S1 sound. So I hear all normal sounds at this point while I'm auscultating at the PMI. So at this point, I will move up to the 4th intercostal space, midclavicular line. And at this point right here, I am listening for the mitral valve. I'll move up to the 3rd intercostal space. And this is the landmark where we call Erb's point. I will move up to the 2nd intercostal space. And this is where I would be able to hear the pulmonic valves opening and closing. So now I'm going to move over to the right side of the 2nd intercostal space. If I can put you can go ahead. And I'll be listening right here for the aortic valve. Right under the aortic valve, I'll be listening for the tricuspid. So now that I'm able to differentiate the S1 and S2 sounds, I'll move back to my PMI, and I will go ahead and I will ask for the patient to go ahead and take in a nice deep breath so that I could hear, so that I'll be able to hear the second splitting of S2. So taking a nice long deep breath. Again, moving up. And then right here at the base, I'll ask her again so that she could go ahead and take another deep breath. Go ahead and take a deep breath for me. Hold it. And at this point, this is where I would be hearing the splitting, the first splitting sound, this one. And I could hear it. So at this point, I will go ahead and I'll ask the patient to go ahead and sit right back up. So I did take the time at the beginning prior to having her lay down. I was able to identify where we had the carotid. I'm going to go ahead and now listen to the carotid pulses. I will be using the diaphragm of my stethoscope in order to listen to these sounds. I was able to hear nice, clear sounds from my from my carotid pulses, and I was able to hear them nice and clear. There were no extra normal sounds when I was listening to the patient's heartbeat. All sounds upon percussion were nice and resonant. Just dull sounds on the left side. Again, that was because of the patient's organs occupying both the left and the right side. At this point, my assessment of the patient, listening to heart sounds in the 6 different spots. We have the 4 along the left side, the 2 on the right side, listening to the heart sounds. All heart sounds were normal. I did also note that the patient's heart rate was a resting heart rate of 72 as well. Patient, again, was breathing 14 breaths a minute. All clear sounds, and this is going to be the end of my assessment. Thank you very much. Have a good day.